Our topic for today is viral conjunctivitis, and I'll be discussing presentation, signs, investigation, and treatment. Starting with introduction. Viral conjunctivitis is a common external ocular infection, and adenovirus is the most frequent causative agent in approximately 90% of the cases. It is a non-enveloped double-stranded DNA virus. It may be sporadic or occur in epidemics in environments such as workplaces, including hospitals, schools, and swimming pools. The spread of this highly contagious infection is facilitated by the ability of the viral particles to survive on dry surfaces for weeks and by the fact that viral shedding may occur for many days before clinical features are apparent. Transmission is generally by contact with respiratory or ocular secretions, including via fomites, such as contaminated towels. Viral conjunctivitis is highly contagious and great care should be taken to prevent transmission of the disease. Now, patients present with varied spectrum from mild subclinical disease to severe inflammation, significant morbidity. There will often be a history of a close contact with acute conjunctivitis. It can be non-specific acute follicular conjunctivitis, which is the most common clinical form of viral conjunctivitis, and this is typically due to adenoviral infection by a range of serological variants. Unilateral watering, redness, irritation, or itching, and mild photophobia occur, the contralateral eye generally being affected 1 to 2 days later, often less severely. The condition is usually milder than the other clinical forms of adenoviral conjunctivitis. Patients may have accompanying, usually mild systemic symptoms such as sore throat or common cold. Pharyngoconjunctival fever is caused mainly by adenoviral serovariants 3, 4, and 7. It is spread by droplets within families with upper respiratory tract infection, as the name indicates. Keratitis develop in about 30% of cases, but is seldom severe. Symptoms are essentially including throat and conjunctiva. The next form is epidemic keratoconjunctivitis, which is caused mainly by adenovirus variants 8, 19, and 37, and is the most severe ocular adenoviral infection. Keratitis, which may be marked, develops in about 80% as compared to pharyngoconjunctival fever, where it develops in about 30%. Photophobia may be correspondingly prominent. Then is the acute hemorrhagic conjunctivitis, which usually occurs in tropical areas. It is typically caused by enterovirus and Coxsackie viruses. Though other microorganisms may present similarly, it has a rapid onset and resolves within 1 to 2 weeks. Conjunctival hemorrhages are generally marked. Conjunctival hemorrhages may also occur in cases of adenoviruses. Then chronic relapsing adenoviral conjunctivitis, giving a chronic non-specific follicular to papillary clinical picture, can persist over years, but is rare and eventually self-limiting. I have already discussed acute hemorrhagic conjunctivitis, which is caused by Coxsackie virus and enterovirus. It can also be caused by adenovirus. Herpes simplex virus can cause a follicular conjunctivitis, particularly in the primary infection. It is also associated with unilateral skin vesicles, systemic viral infections such as those common in childhood. For example, varicella, measles, and mumps can feature associated follicular conjunctivitis. Varicella zoster or chickenpox virus, secondary infection, commonly causes conjunctivitis as a part of ophthalmic shingles. Conjunctivitis secondary to HIV infections is also recognized. Now, an important virus is molluscum contagiosum. It is a skin infection caused by human-specific double-stranded DNA pox virus that typically affects otherwise healthy children, with a peak incidence between the ages of 2 and 4 years. Transmission is by contact with subsequent autoinoculation. A chronic follicular conjunctivitis can be associated and is due to skin lesions shedding of viral particles. Chronic unilateral ocular irritation and mild discharge is typical. The eyelash line should be examined carefully in patients with chronic conjunctivitis so as not to overlook a molluscum lesion. Now, upon examination, there is eyelid edema, which ranges from negligible to severe. Lymphadenopathy is common, and tender preauricular nodes are observed. Conjunctival hyperemia and follicles are typical in cases of viral conjunctivitis. Papillæ may also be seen particularly in the superior tarsal conjunctiva. Severe inflammation may be associated with conjunctival hemorrhages, usually petechial and adenoviral infection, chemosis, and membranes are rare, and pseudomembranes sometimes with conjunctival scarring after resolution might appear. Anterior uveitis is sometimes present, but it is mild. Now, keratitis is one of the debilitating sign, which might present as epithelial microcysts which do not stain at an early stage in cases of adenovirus. Then punctate epithelial keratitis, which stains may occur usually within 7 to 10 days of onset of symptoms, typically resolving within 2 weeks. Afterwards, focal white subepithelial anterior stromal infiltrates, as seen in first picture at the top, develop beneath the fading epithelial lesions, probably as an immune response to virus. They may persist or recur over months or years. Small pseudodendritic epithelial formations sometimes occur. Now, molluscum contagiosum, we already discussed it. It's a pale, waxy, umbilicated nodule on the lid margin, as it is seen in the pictures, in the second picture and in the third picture. Now, this is the umbilicated lesion here on the lid margin, and there is another lesion here, and they are associated with follicular conjunctivitis. They cause mild watery and mucoid discharge. Bulbar nodules and confluent cutaneous lesions may occur in immunocompromised patients. Investigations are generally unnecessary, but should be considered if the diagnosis is in doubt or there is failure of resolution. James's stain shows predominantly mononuclear cells in the adenoviral conjunctivitis and multinucleated giant cells in herpetic infection. Nucleic acid amplification techniques such as PCR are sensitive and specific for viral DNA. Viral culture with isolation is the reference standard but is expensive and fairly slow and takes days to weeks and requires specific transport media. Sensitivity is variable but specificity is around 100%. A point of care immunochromatography test takes 10 minutes to detect adenoviral antigen in tears. Sensitivity and specificity are excellent. Serology for IgM or rising IgG antibody titers to adenoviruses has limitation and is rarely used. Investigations for other causes such as chlamydial infection may be indicated in non-resolving cases. Coming towards treatment, the treatment of disease is tailored according to the cause. Spontaneous resolution of adenoviral infection usually occurs within 2 to 3 weeks, so specific treatment is typically unnecessary. No antiviral agent with clinically useful activity against adenovirus has yet been produced. Reduction of transmission risk by meticulous hand hygiene, avoiding eye rubbing and towel sharing. There should be scrupulous disinfection of instruments and clinical surfaces after the examination of an infected patient. For example, sodium hypochlorite and povidone iodine can be used. In cases of molluscum contagiosum, although lesions are self-limiting in immunocompetent patients, removal is often necessary to address secondary conjunctivitis or for cosmetic reasons. Expression is facilitated by making a small nick in the skin at the margin of the lesion with the tip of a needle. Topical steroids such as prednisolone 0.5% 4 times daily may be required for severe membranous or pseudomembranous adenoviral conjunctivitis. Symptomatic keratitis may require weak topical steroids, but these should be used with caution as they do not speed resolution but only suppress inflammation and lesions commonly recur after premature discontinuation. Steroids may enhance viral replication and extend the period during which the patient remains infectious, and intraocular pressure should also be monitored if treatment is prolonged. Some other measures like discontinuation of contact lens wear until resolution of symptoms, artificial tears 4 times daily may be used for symptomatic relief. Preferably preservative-free preparations may give superior comfort and if supplied in a single dose units may reduce transmission risk. Cold or warm compresses for symptomatic relief. Topical antihistamines or vasoconstrictor may improve symptoms, particularly in itching. The place of non-steroidal anti-inflammatory drops is not well established, but may be effective in some circumstances such as steroid weaning. They are not thought to promote viral replication. Removal of symptomatic pseudomembranes or membranes. Topical antibiotics if secondary bacterial infection is suspected. Uh, Povidone iodine is very effective against free, although less so against intracellular adenoviral, and has been proposed as a means of decreasing infectivity. So this is where we'll conclude our lecture of viral conjunctivitis. And if you like the lecture, please press on the like button and subscribe to the channel. Thank you all.